Assalamu alaikum and good evening, my dear students. I am Professor A Matin. We are talking about IVA examination. In last class, actually, I missed. So today's 2 weeks ago, I discussed some topics for your exam. So we're starting with that. We discussed the pharynx anatomy and what is important for your exam, like Wilder saying. This time also, the questions came in the professional examination, that means supplementary examination, about Wilder string, Drouin level Wilder string. So this is very important for exam. And blood supply tonsil as well, this also came in this exam. So this is very important about the Wilder string and blood supply of tonsils. Now, this is the nasopharynx. Adenoid this time also came. So adenoid is very important for exam. How the patient presents with clinical scenario of adenoid treatment, what investigation you want to ask for, this is important. Juvenile nasopharyngeal angiofibroma, like a patient's teenage boy presents with recurrent epistaxis, nasal obstruction, cheek swelling. What is your diagnosis? So juvenile nasopharyngeal angiofibroma. Regarding NPC, that means nasopharyngeal carcinoma, this is also important for exam, like what are the common presentation, etiology of nasopharyngeal carcinoma we discussed. Especially don't forget that a bimodal presentation. Patient may be younger, maybe older age patient with nasal obstruction, blast change, nasal discharge, lymph node metastasis, problem in the ear like your otitis media with effusion. These are the features of nasopharyngeal carcinoma. And treatment option we discussed, right? Don't forget radiotherapy is one of the important treatment options, radiotherapy. Sometimes if it recurs, then you can also go for some surgery like nasopharyngectomy. You can also go for neck dissection. Tonsil is very important for exam. Your short cases we discussed. Acute tonsillitis, chronic tonsillitis, peritonsillar abscess, cause of white patches. This time also came in your professional examination. That what are the causes of white patches over the tonsil area we discussed, and how you investigate we discussed. Don't forget blood count and also throat swab as well as monospot test for white patches. Tonsillectomy in details, complication of tonsillectomy, especially reactionary hemorrhage. What are the causes of reactionary hemorrhage? How to manage reactionary hemorrhage is also important. Acute tonsillitis, if you don't treat, what are the complications of acute tonsillitis? So don't forget about your peritonsillar abscess, parapharyngeal abscess or retropharyngeal abscess from tonsillitis, acute glomerulonephritis, cardiac problems, kidney problems or AGN. Next was infection, acute retropharyngeal abscess, important, like clinical scenario, a child presents with sudden rise of temperature, sore throat, difficulty in eating and drinking, dysphasia, and respiratory distress, or stridor. So one of the important conditions is acute retropharyngeal abscess. X-ray soft tissue, neck lateral view showing lots of features. It's important for your exam, your OSPE as well as in oral examination. Chronic retropharyngeal abscess is due to tuberculosis or Pott's disease. So you have to remember that. Ludwig syndrome we discussed is a submental cellulitis and mostly from dental infection. Now today's topics about the esophagus. What are the common questions we asked in this? What about the anatomy of esophagus? We hardly ask this question in the exam, in oral exam, but sometimes you say, tell me about the length of esophagus, how long it is, where it starts and where it ends. This is very important for your exam. So esophagus is a muscular tube about 25 centimeter in length. It's starting from the cervical 6 vertebral column, that means from the cricoid cartilage at the level of cervical 6 vertebra, and then it ends when it pierces the diaphragm and enters into the cardio-esophageal junction. That means you're at the level of 11th thoracic vertebra. So this is very important. And what are the common constriction of esophagus? It's very important for exam. So we have 4 constrictions esophagus, and we measure from the incisor teeth. When we do an endoscopy or esophagoscopy, we usually measure from the length from the incisor teeth. So starting first constriction at the beginning of the esophagus at the 6th vertebral level. So this is the first constriction, about 15 centimeter from the incisor teeth. And then second one is when the esophagus is crossed by the arch of the aorta, about 22 centimeter from the incisor teeth. Third is when it's closed by the left principal bronchus, about 27 centimeter from the incisor teeth. And the fourth one is your at the finishing or end of the esophagus when it's enters in the stomach. I mean the esophageal cardiac junction, and it's about 40 centimeter from the incisor teeth. So these are the constriction you have to know in your exam. Sometimes you also put this question in the written paper. So that is the basic anatomy of esophagus. Blood supply is not that important, but as you know, the esophagus is divided into 3 divisions. One is your cervical esophagus, one is your thoracic esophagus, is the longest one, and the abdominal esophagus. So the thoracic esophagus, cervical esophagus is supplied by the inferior artery, thoracic esophagus from the branch of the descending thoracic aorta, and abdominal esophagus by the left gastric artery. So very simple. This is the blood supply. Physiology, okay. Then your dysphasia is very important for exam. We usually ask causalology of dysphasia in the written paper as well as in the oral exam. Tell me about some causes of dysphasia. As you know, the dysphasia, any difficulties in swallowing is called dysphasia. And what is odynophagia? It is painful deglutition. This is called odynophagia. So dysphasia, if I ask the question in the exam, what are the causes of dysphasia? You can also tell some causes in the oral cavity and oropharynx like carcinoma of the tongue, aphthous ulcer, acute tonsillitis, peritonsillar abscess, retropharyngeal abscess. They also causes dysphagia like lattice angina as well. But sometimes we ask the question, tell me some esophageal causes of dysphagia. So esophageal cause of dysphagia confined to the esophagus, and we usually prefer to just hear this, what are the problems in the esophagus which causes dysphagia? Or tell me 5 esophageal causes of dysphagia. So try to confine to the esophageal cause. Maybe in the lumen, maybe in the wall, maybe outside, but doesn't matter. Classically, you can tell some common diseases in the esophagus which causes dysphagia. Like the first thing is your carcinoma of the esophagus, classical cause of dysphagia. Carcinoma of the esophagus, number 1. Number 2 is your stricture esophagus from previous history of corrosive injury. Okay. Number 3, foreign body in the esophagus. Number 4, pharyngeal pulse. And number 5, achalasia cardia. So these are the 5 classical common causes of dysphagia. But other causes like pressure from outside, like retrosternal goiter, dysphasia lysuria, there's some disease, or abnormal blood vessel which can press the esophagus. So these are the classical causes of dysphagia. Now, we ask these questions about Plummer-Vincent syndrome in different scenarios. Straight away, you can ask, tell me about Plummer-Vincent syndrome. It can be coming in the written paper as well. Or you can ask the question in the clinical scenario, like a 55 years old female patient presents with sore tongue, dysphasia, iron deficiency anemia or colonakia, and on palpation of the tummy or stomach or your abdomen, you can get a lump in the abdomen. That means splenomegaly. So what is your diagnosis? That means, so this is a classical case of Plummer-Vincent syndrome. So Plummer-Vincent syndrome, the etiology is, you know, this is maybe a genetic, maybe a iron deficiency, because most of the cases you'll get a iron deficiency anemia or colonakia. So iron deficiency may be a contributing factor for Plummer-Vincent syndrome. So the classical presentation is mostly in a female patient, in middle-aged women presenting with a dysphasia, progressive dysphasia, to solid and liquid. Patient have a sore tongue. If you examine the patient's oral cavity, you'll get a very red beefy tongue. There is loss of normal tongue papillae. So there's very smooth, shiny tongue, red, angry-looking tongue. You could get a glossitis. You can get an angular stomatitis. You can get a koilonychia. You can get say pale, iron deficiency anemia. And if you palpate the tummy or abdomen, you'll get a splenomegaly. So these are the features of Plummer-Vincent syndrome. It's actually, another name is Peterson-Brown-Kelly syndrome. Plummer-Vincent syndrome from the American physicians and surgeons. Also, another name is Peterson-Brown-Kelly syndrome, PBK. So these are the clinical features of Plummer-Vincent syndrome. The questions may come in different way, maybe clinical scenario or just straight way. Okay, so how do you investigate Plummer-Vincent syndrome? What are the complications of this disease? So the investigation, as you know, the routine blood CBC will get a iron deficiency anemia, low hemoglobin. The serum iron level is very important rather than hemoglobin level. The serum iron level will be low. So low serum iron, and there will be TIBC will be increased. That means total iron binding capacity will be increased, and serum iron will be low. You can get a sonogram to see the splenomegaly sometime. So this is the features and scenario of Plummer-Vincent syndrome. What else? You can get a barium swallow as the patient presents with dysphasia. Any patients with dysphasia, the classical investigation, radiological investigation is your barium swallow. So if you get a barium swallow, you can get a esophageal wave or esophageal diverticulum. It's called post-cricoid wave formation in Plummer-Vincent syndrome. And then number 3 investigation is you can also get an endoscopy. If you do endoscopy, you can get this wave. You can also see sometimes a malignant transformation or cancer because this is a precancerous condition. So these are the investigations. But classical investigation for Plummer-Vincent syndrome is your serum iron level will be low and increased total iron binding capacity. Okay. Other investigation, as I said, barium swallow and endoscopy. Now, how to treat Plummer-Vincent syndrome? So treatment is your iron supplement in the form of oral iron. Sometimes you can give parenteral iron, or if the severe anemia, patient may need a blood transfusion. Most of the cases, if you supplement the patient with iron, the patient's condition improves. Usually improves with this iron supplement, okay? Sometimes you can give parenteral iron therapy. And if the patient has got still dysphasia, if the patient has got a post-cricoid wave formation, then you can also go for endoscopic dilatation of the wave for easy, for relieving of the dysphasia. If you suspect, yes, patient might have a cancer, you can get a biopsy, okay? So this is about Plummer-Vincent syndrome, and complication of this is your, the chance of post-cricoid, as there is a wave formation, so there is a chance of post-cricoid carcinoma cancer, and this is also a precancerous condition of the esophagus. Okay, so there is a chance of carcinoma of the esophagus. This is all about Plummer-Vincent syndrome. Regarding this, we sometimes ask this question in the exam. Tell me about precancerous condition of the esophagus. This is a very classical question asked in the exam, in oral exam as well as in your written paper. So classical precancerous condition of the esophagus is your aclasia, pharyngeal pouch, Plummer-Vincent syndrome, Barrett's esophagus, stricture esophagus, gastroesophageal reflux disease, tylosis. So these are the precancerous condition of the esophagus. Don't forget Barrett's esophagus is another important precancerous condition of the esophagus. Okay, next is your aclasia. This is a classical disease asked in the exam, written paper, as well as short notes, as well as oral exam. Now, how do you ask this question in the exam? We usually give a clinical scenario in the written paper as well as oral exam, that a 22 or a 30 years old young lady presents with dysphasia, weight loss, and anemia. After querying the history or investigating the patient notices the dysphasia more to liquid than solid. That means the patient has got more dysphasia or difficult in drinking rather than eating solid food. So liquid food or drinking more problem than the swallowing solid food. So what is your diagnosis? So in this the clue, the patient has got dysphasia, patient weight loss, but the dysphasia is more to liquid than solid. And this is the classical condition of achalasia cardia. So that is the scenario of achalasia cardia. What is achalasia cardia? So achalasia cardia is defined as a neuromuscular incoordination of the esophagus or neuromuscular disorder where the lower esophageal sphincter fails to relax during normal physiological swallowing. And that is due to degeneration of the mesenteric plexus. Degeneration of the mesenteric plexus. So in the lower esophageal sphincter, as you know, when you swallow food, or when the esophageal peristalsis is coming up, the lower esophageal sphincter is called LES, is automatically dilate or open up the sphincter to allow the food into the stomach. So in this achalasia cardia, the patient is eating, but the lower esophageal sphincter is closed. It's not opening. The gate is not opening. So what happened? The food is gradually accumulated in the esophagus. Initial stage, the food is accumulated in the esophagus, but eventually, when there is a food bolus, the gravity can pull the food downwards. So patient have that the solid food can easily sometimes go along its gravity. But the liquid has very lighted. So the gravity doesn't work on liquid. That's why the patient has got more problem in swallowing or drinking liquid food. Eventually the food is going down due to the gravity. And as the food is accumulated in the esophagus, so the esophagus is more and more dilated. That is the classical feature of achalasia cardia. There is a dilated esophagus, or it's called mega esophagus. So what are the common complaints of achalasia cardia? The patient presents, the female patient mostly, younger age group, patient presents with progressive dysphasia, more to liquid and then solid. Gradually, patient have got regurgitation of undigested food. When the patient sleep at night, the sudden bouts of coughing because the food is regurgitated, sometimes slipping down to the larynx, and the patient has got recurrent coughs. Patient has got anemia, patient has got weight loss gradually, patient unable to eat and drink because his food is not going down straight away. So patient has got anemia, dysphasia, loss of weight, all these, and recurrent bouts of coughing, sometimes regurgitation of undigested food. These are the features of achalasia cardia. Now, if you suspect this is achalasia cardia, then how do you investigate? As I said, any patients with dysphasia, the number one investigation is your barium swallow. And this will be given in your exam, in your OSP examination as well. The barium swallow of achalasia cardia will be given in the exam. So what we get in achalasia cardia, barium swallow? The barium swallow, there will be huge dilatation of the esophagus along its whole length, excepting the lower end when there is a smooth, narrow, or narrowing like a pencil tip. The lower end is smooth, narrowing like a pencil tip, and proximally the esophagus is dilated. This is a classical feature of the achalasia cardia. And there will be some residual shadow, negative shadow in the lumen of the esophagus. This is indicating the residual food debris. Okay, so this is achalasia cardia. How to differentiate from carcinoma esophagus in the barium swallow? In barium swallow, in case of carcinoma esophagus, there will be irregular filling defect, and the esophagus is not that much dilated. Okay, irregular filling defect lower end like your rat tail appearance, but here is a pencil tip. Okay. So achalasia cardia, this is. Now, is there any other investigation of achalasia cardia? Well, you can also go for endoscopy, esophagoscopy, to see that the sphincter is very tight, and there is also lots of food debris, esophageal food debris in endoscopy or esophagoscopy, number 2. Number 3, you can also see the intraluminal lower end of the esophagus pressure, lower esophagus sphincter pressure by manometry. So, esophageal manometry to measure the pressure of the lower end when there's a very high pressure. And also, we can also go for ambulatory 24 hours pH monitoring to see the reflux. So these are the common investigations, but classical investigation is a barium swallow of the esophagus. Now, how to treat aclasiocardia? This is very important for exam, oral exam as well as written paper. So aclasiocardia treatment, medical treatment and surgical treatment. Medical treatment in the form of, we can use some anticholinergic drugs, calcium channel blocker like nifedipine, 10 milligram, half plus, 0 plus half for 2 months or 3 months. Sometimes this drug can work, it's a calcium channel blocker to improve the sphincter activity and can relax the sphincter and give some improvement. The calcium channel blocker, nifedipine, sometimes it works. And then we can also destroy the sphincter by botulinum toxin A, Botox. Botox injection is also research work. Now it works in aclasiocardia. So these are the treatment. Number 3 treatment is surgical procedure. We can also go for endoscopic dilatation of the lower esophageal sphincter by Markari bougies. We can use some pneumatic bougies, different sizes, gradually, initially small diameter and then large diameter and then graduated large diameter like you're dilating the stricture urethra. So endoscopic dilatation of the esophagus by Markari bougies, that is another option. But nowadays it's very important, rather than ENT surgeon, all the gastroenterologists or endoscopists, they can treat aclasiocardia by dilatation of the lower esophageal sphincter by pneumatic balloon. So balloon dilatation of the lower esophageal sphincter. This is another options of aclasiocardia. Now, last is definitive operation for aclasiocardia is your Heller's cardiomyotomy. Heller's cardiomyotomy. We can explore the lower esophageal sphincter by upper midline incision, and then we can go to the lower esophageal sphincter. We can make an incision, particularly downwards along the serous layer, then muscle cord down to the mucosa. So when we cut the muscle cord about 5 centimeters, the mucosa will prolapse. That means we destroy the sphincter. This is the Heller's cardiomyotomy. The only problem is sometimes if you do a sphincterotomy, there may be regurgitation. So sometimes you can also go for some sorts of anti-reflux treatment like fund duplication of the lower sphincter. But for you people, it's not that much important. For you people, only the drug treatment, as I said, nifedipine. Number 2, Botox or botulinum toxin. Number 3, dilatation of the lower esophageal sphincter by Markari bougies or by pneumatic balloon. And number 4 is your Heller's cardiomyotomy. That's it. That is all about your aclasiocardia. The risk of aclasiocardia is the precancerous condition. Okay. So that is all about aclasiocardia. Next topic of esophageal disease is carcinoma esophagus. This usually present on that way. Like suppose a 65 years old male or female patient presents with progressive dysphasia, weight loss, anemia. Dysphasia is initially with solid and then liquid. So dysphasia, progressive dysphasia to solid and eventually end up with liquid, with weight loss, cachextic patient, anemia. What is your diagnosis? This question also I asked in PSC examination. Last 2 or 3 sessions I am a PSC examiner. So in a BCS exam, I usually ask this question in the Viva board. Okay. So classical condition is a patient with progressive dysphasia to solid and liquid, weight loss, anemia. What is your diagnosis? The classical diagnosis is carcinoma of of the esophagus. This is the classical diagnosis of carcinoma of the esophagus. So this is a scenario we usually put in this exam, in the oral exam. Or straight away you can tell me about carcinoma of the esophagus. We hardly ask this question straight away. Tell me about carcinoma of the esophagus. We ask this question in clinical scenario, in your real exam as well as in your Viva exam, in your written paper, that a patient presents with dysphasia, solid and liquid, weight loss, anemia, cachexia, malnourished patient. What is your diagnosis? So we diagnose carcinoma of the esophagus. Now, as you know, carcinoma of the esophagus, as you know, the pre-cancerous condition of the esophagus I discussed. How do we investigate this patient? So, if we suspect carcinoma of the esophagus, the first thing is we will ask a barium swallow. A barium swallow. A barium swallow will show the classical features of carcinoma of the esophagus. What are those? The barium swallow will show a irregular filling defect in the upper part or mid part or lower part of the esophagus. It is lower part, so irregular filling defect like a rat tail appearance. Proximally, there is slight dilatation, not like a huge dilatation, slight dilatation of the esophagus. It's a classical case. Is carcinoma esophagus. Next is your flexible endoscopy or rigid endoscopy and get a biopsy. So endoscopy and biopsy is the number 2 investigation. Number 3 investigation, if you suspect the advanced stage, you can also get a CT scan of the chest and neck as well. But classically, your barium swallow and endoscopy and biopsy is enough for you. After confirmation of treatment, after confirmation of diagnosis, so you have to treat the patient. How do you treat the patient? It depends on actually, most of the cases the patient needs, as is commercial carcinoma, most of the cases patient need a radiotherapy, is a classical treatment. Patient may have chemoradiation. If it is in the lower end of the esophagus, if we can approach the lower end of the esophagus, then there's another option, is surgical option. We can excise the esophagus, the segment of the esophagus, and make anastomosis with the stomach, it's called gastric pull-up, or with colonic transposition. Or we can make anastomosis with the free jejunal graft. We take a segment of the jejunum with the jejunal artery and then take it in the neck and make anastomosis with the proximal part of the esophagus and distally with the stomach and with the blood supply to the nearest your artery, like your infothyroid artery, like gastric artery with the jejunal artery. So this is your free jejunal graft, or you can gastric pull-up or colonic transposition. These are the treatment of carcinoma of the esophagus. Sometimes in inappropriate cases, we can pass a endoscopic NG tube, some sorts of tube for tube feeding. If the patient is very advanced stages, we can also go for percutaneous feeding. It's called percutaneous endoscopic gastrostomy or peg feeding. We can also give terminal care, palliative radiotherapy or chemotherapy. We can also, if the patient is unable to eat and drink, then we can give a feeding gastrostomy or feeding jejunostomy for nutritional support. Feeding jejunostomy or feeding gastrostomy for nutritional support. These are all about the carcinoma esophagus. Another scenario, we asked this question in the exam. Suppose a 70 years old or 75 years old male patient presents with progressive dysphasia, weight loss, and recurrent bouts of coughing during sleep, and regurgitation of undigested food that he remembers eating few days back. That means this is a classical patient, aged patient presents with progressive dysphasia, weight loss, anemia, and recurrent bouts of coughing during sleep and regurgitation of undigested food. Suppose he had a food 3, 4, 5 days, 7 days ago, and that is coming up with regurgitation. What is your diagnosis? What is your diagnosis? So diagnosis, pharyngeal pause. Pharyngeal pause. Pharyngeal pause, as you know, this is a condition. This pause usually, or is a diverticulum. It's called Jenker's diverticulum. Jenker's diverticulum. As you know, the esophagus, if you know the anatomy of the esophagus, the lower esophageal, there is a space actually. It's called dehiscence. That means it's called Killen's dehiscence. So the pharyngeal pause occurs at Quillen's dehiscence. There is a space between the, there are two divisions of the inferior constrictor muscle. One is thyropharyngeus and cricopharyngeus muscle. In between the thyropharyngeus and cricopharyngeus, there is a space or gap. Only the mucosa is there, no muscle core. This is called Quillen's dehiscence. So due to the intraluminal pressure, for any regions, incoordination of movement, increased intrapharyngeal pressure or lower sphincter pressure, there is expulsion diverticulum. That means expulsion of the mucosa through this space, like your herniation of the pharyngeal mucosa through Quillen's dehiscence. That is called pharyngeal pause, and that occurs here. And this is called Jenker's diverticulum. So this is pharyngeal pause. Now the investigation, as you know, you can go to barium solo, you can go to endoscopy, you can see the diverticulum. Treatment of pharyngeal pause, there are different treatment of pharyngeal pause. Usually we divide the septum between the pause and the esophagus. So there is a septum between the pause and the esophagus. There's a patient presents with dysphasia. We can divide the septum with diathermy. It's called Dolman's procedure. We can stepping the septum, we can cut the septum. We can also excise the diverticulum, it's called diverticulectomy. So there are different options of treatment of pharyngeal pause. Pharyngeal pause is not that important of you, it's mostly postgraduate, but if I am an examiner, sometimes I ask this question. I love asking this question of pharyngeal pause, the scenario. Okay, so that is all about pharyngeal pause, and pharyngeal pause is also important for your exam. Now, what about the foreign body esophagus? We usually put this question in the OSP, that is X-ray, plain X-ray, soft tissue, neck lateral view. You can see a radiopic shadow in the prevertebral space at the level of 7, 6 or 7 or 8 cervical vertebra. So this is a foreign body in the esophagus. And then I will ask the question, how do you treat this patient? The treatment is endoscopic removal of foreign body under GA. What are the common foreign body at the esophagus commonly impacted? As you know, the classical foreign body of the esophagus in case of children is a foreign body is your coin or metallic coin, usually 1 taka note, 5 taka note, or 50% note. These are the common in children. The foreign body esophagus in case of adult or another region, the mid bone is a classical. In either patient, mid bone or mid bolus. In extreme age patient, mid bolus, the bulk of or bolus of meat can impact it in the esophagus. So mid bolus, foreign body, especially the mid bone or fish bone can impact it in the esophagus. These are the common foreign body in the esophagus. And other is extreme old age, those who put denture. So denture is another important foreign body. So denture is another important foreign body. These are the common foreign body in the esophagus. Then the question is, how do you treat endoscopic removal of foreign body under GA? Is there any complication of this procedure? That's very important. If you deal with the mid bone or denture, when you try to remove, you can tear the esophagus. So this question is coming up in the exam. Suppose you do an endoscopy or esophagoscopy and you got a perforation of the esophagus. How do you understand clinically that patient got perforation? So perforation of the esophagus clinically, first thing is when you do the procedure, you can notice, oh my God, I entered into some other spaces. I'm not in the lumen. So that is one, sudden loss of resistance. Number two, you can get some sound of perforation. You can get some bleeding, abnormal bleeding from the esophagus. And then after procedure, we always palpate the neck. What do you palpate? We palpate the surgical emphysema. If you tear the esophagus, then there is tracking of air is coming up in the subcutaneous space. So after esophagoscopy, we always palpate the neck for subcutaneous emphysema or surgical emphysema. This is the number 1, 2, 3, 4. Then after recovery of the patient complains of severe pain in the back. So patient complains of throat pain, retrosternal pain, pain radiating toward the back. This is the classical features of perforation of the esophagus. Now the next question is, how do you manage this patient? So the treatment of perforated esophagus or perforation of the esophagus. Now it depends on, sir, the treatment depends on site of perforation is in the cervical esophagus or it's in the thoracic esophagus. Cervical esophagus, if I tear, nothing to worry. If I try to pass the NG tube, we put NG tube, or we can put on NPO, nothing in my mouth, intravenous antibiotic, ceftriaxone and flagyl or metronidazole, and then swallow the patient, no painkiller, usually just supportive treatment, and then how it goes. Most of the cases with NPO, the cervical esophagus heals very nicely. But if it has got an abscess here, we can drain the abscess. So this is cervical esophagus. But sir, if we clear the thoracic esophagus, then this is very dangerous situation because most of the patients will develop mediastinitis and high mortality. About 80 to 90% mortality, patient will die from this. That's why, sir, if we clear the thoracic esophagus, then the patient needs immediate transfer of the patient to a thoracic hospital, or we call the thoracic surgeon first thing, and then we have to open the thorax. That's called thoracotomy. Open thoracotomy, and then repair of the perforation, and then water seal drainage. So open thoracotomy, repair of thoracic esophagus, repair of perforation, and then put a water seal drainage and intravenous antibiotic. Patient may need ICU support. So these are the treatment of perforated esophagus and front esophagus. All about this. What else? So I think there is another scenario. Suppose we have this question in the exam like that. Suppose a patient, young patient, about 25 years old female patient presents with progressive dysphasia to solid and liquid for 2 to 3 months. On taking history, the patient gives a history of corrosive ingestion, or she tried to suicide, and she or he swallowed some corrosive acid. 3 months later, she develops this dysphasia to solid and liquid. What is your diagnosis? So classically, sir, my diagnosis, a benign stricture of the esophagus. So stricture of the esophagus, benign stricture of the esophagus. Now, how to treat this stricture esophagus? Sir, early stage, we can try to dilate the stricture. If it's small segment stricture, we can dilate this with a mercury bougies or pneumatic balloon. Patient may need serial dilatation of the esophagus. But if it is very frequent or is unable to dilate with the esophageal bougies, then sir, we have to go for operation. That means we have to excise the segment of the stricture, and we can make a bypass with your gastric pull-up or with a free jejunal graft or with colonic transposition. So this is all about esophagus. Next is your larynx. Now, the larynx actually, these are two very important topics, esophagus and larynx. Larynx is also important, very important for exam, for written paper as well as for your oral exam. First thing is anatomy and physiology of larynx, what we ask in the written paper as well as in the oral exam. Now, tell me about what are the laryngeal cartilages. So laryngeal cartilages are paired cartilage and unpaired. Unpaired cartilages, as you know, this the epiglottis, the thyroid, and the cricoid cartilage. These are the unpaired cartilage, single cartilages. And paired cartilages are, as you know, arachnoid cartilage, cornicular cartilage, and cuneiform cartilages. So we have paired cartilages and unpaired cartilages. The paired cartilages are arachnoid, corniculate, and cuneiform, and unpaired cartilages are your epiglottis, your thyroid cartilage, and your cricoid or cricoid cartilage. This is anatomy. Now, tell me about the muscles of the larynx. So the muscles of the larynx, the intrinsic muscles and extrinsic muscles. Mostly we are talking about the intrinsic muscle of the larynx. Now tell me about who is the abductor of the larynx. That means who opens the glottis. Single most important muscle in the body. If I say what is the single most important muscle of the body, which keep us alive, and that is the single most important muscle of the body is your posterior cricoarytenoid muscle. Posterior cricoarytenoid muscle, which abduct the vocal cord and open the glottis. That is single most important muscle, not diaphragm. If we paralyze the diaphragm, still we can survive. But this is a muscle who is open the rima glottis or glottis so that we can breathe through the larynx. This is the posterior cricoarytenoid. So this is the abductor of the larynx. Now, what are the adduction? Who closes the glottis for voice production? There are some muscles. It's called thyroarytenoid muscle, lateral cricoarytenoid muscle, interarytenoid muscle, thyroepiglotticus. So these are the muscles which adduct the vocal cord. What is the function of the vocalis muscle as well as cricothyroid muscle? The cricothyroid muscle which tenses the vocal cord for quality of voice, like a singer, politician, those who want to shout or make a good voice. So the cricothyroid muscle tenses the vocal cord. Now, regarding the anatomy, these are the most important anatomy. Next question is the division of the larynx. The larynx is divided into 3 divisions. One is supraglottis, another glottis, another subglottis. The part of the supraglottis, we put this in the MCQ as well as some oral exam. When we're talking about the cancer of the larynx, we divide the larynx into 3 divisions: supraglottic cancer, glottic cancer, and subglottic cancer. So what is supraglottis, what is glottis, what is subglottis? Supraglottis is above the glottis. That means the vestibular fold or false vocal cord, the ventricle of the larynx, the arytenoid, epiglottic fold, and epiglottis. These are all supraglottis. Glottis is your true vocal cord. These are two vocal cord, the anterior commissure, posterior commissure, and 2 vocal cord. These are the glottis. And below 5 millimeter below this is subglottis. So that is all about division of the larynx. Now, physiology of larynx. What is the function of larynx? What does it do? The most important function of larynx is, as you know, there are some functions like your, it's a passage for respiration. We are breathing through the larynx. So this is the passage for respiration, number 1. Number 2, we are talking with larynx. So that means the larynx is responsible for your speech. We talk with the larynx. How? The 2 vocal cords, they move when the air flow from the chest, from the lungs, flow the vocal cord, so they vibrate, and we talk with the vibration of the vocal cord. But is it the real physiology? No. As you know, when the air flow passes through a tube, when there is a constriction, the air drop. This is called Poisson mechanism. So what happens here? The subglottis is the narrowest part, and when the air flow from down up, the air drops in the subglottis, and they suck the vocal cord. And again, another flow, they suck the vocal cord. In this way, repeated sucking and dropping of the air flow, they produce a mucosal wave. So in the glottis, there is a subepithelial space or mucus space, and the vibrating vocal cord, they vibrate, just vibrate like a tuning fork, and the mucosal wave, they produce voice. So that is number 2 is the production of voice. Number 3, as you know, when you swallow, eat and drink, the most important function is your production of the lower respiratory tract by larynx. How? If you eat and drink, if the larynx is not closed, the food can go inside and causes cough reflex, and also causes serious aspiration. So the most important function of the larynx is prevention of aspiration. That means when you eat and drink, all the 3 sphincter, like your epiglottic fold, like a vestibular fold, like true vocal cord. So 3 layers closes and stop respiration. And then the food divert, the epiglottis divert the food to the pharynx, hypopharynx, and esophagus. And that is food is not going to the larynx. This is the important function of larynx, is protection of the lower respiratory tract during swallowing by closing the glottis, supraglottis. Okay. So this is the most important function, is prevention of aspiration. And then cough reflex, another function, another is to produce the positive intra-abdominal pressure for parturition, for micturition, for any of the forceful valsalva. This is important, is your larynx. Then next question is, tell me about hoarse voice. What are the causes of hoarseness of voice? And in the exam, you're blank actually. So as you know, the voice is produced by 2 vocal cords. So any damn lesion in the vocal cord, any damnation in the vocal cord causes hoarse voice. What are those? So think of that. Any damnation in the vocal cord causes hoarse voice. So number one is a vocal cord nodule. Number two, vocal cord polyps. Number three, vocal cord papilloma. Number four, vocal cord cancer or laryngeal cancer. And number five, vocal cord paralysis. If the vocal cord doesn't move. So these are five classical causes of hoarse voice. Vocal cord nodule, vocal cord polyp, vocal cord papilloma, vocal cord cancer or carcinoma larynx, and then vocal cord paralysis. So these are classic. Other is like your infection vocal cord, like acute laryngitis, chronic laryngitis, laryngeal tuberculosis. Okay, that causes hoarse voice. So these are the causes of hoarse voice. Now we ask this question. Now, if a patient comes with hoarse voice, how to investigate? So as you know, the first thing is hoarse voice. We have to examine the patient's larynx. How will examine patient's larynx? By indirect laryngoscopy examination. Now, IL mirror with laryngeal mirror. What are the structures seen by indirect laryngoscopy examination? This question asked in the exam, in MCQ, in written paper, as well as draw and label IL finding. Okay, so you just draw a circle and the two vocal cords like this, and above is epiglottis, two vocal cords, tracheal ring, aryepiglottic fold, arytenoid, false vocal cord. Okay, only one point you cannot see with the indirect laryngoscopy is a ventricle of the larynx. Between the true and false vocal cord, there is a space or cleft. This is called ventricle of the larynx. We cannot see with the IL mirror examination. Okay, so structure seen by indirect laryngoscopy, we know. Investigation of hoarse voice. So the first thing is we examine the person with indirect laryngoscopy examination. If we fail, we can pass a flexible nasolaryngoscope. It's called FOL. With the FOL, we can see the whole larynx. Then direct laryngoscopy. Under GA, direct laryngoscopy and examine the larynx. If any lesion, you can get a biopsy. If there is a procedure you can do, like your vocal cord nodule polyp papilloma, you can exercise. Okay, so this is the investigation. And also if you think of the cancer of the larynx, then you see get a CT scan of the larynx. Okay, these are the investigation. Next question is stridor in larynx. Very important question in the exam is stridor. Define stridor. What is stridor? What is stridor? So stridor is defined as a noisy breathing due to partial airway obstruction at or below the level of larynx. This is stridor. This is stridor, okay? So stridor is defined as a noisy breathing due to partial airway obstruction at or below the level of larynx. Now tell me, cause of stridor. We usually ask this question in the exam. Suppose stridor in children, we are talking about paroxysmal stridor and we are talking about aparexual stridor. This time also this is put in the exam in your written paper. So stridor, paroxysmal stridor in children and aparexual stridor in children. Very for oral exam as well as for short essay question paper. So let us talk about aparexual stridor in children. That means stridor without any fever or temperature. Number one is your laryngomalacia. Number two is your laryngeal wave. Number three is your subglottic hemangioma. Number four is your foreign body in the larynx. And number five is your multiple papilloma larynx. This time, this question asked in the written paper, multiple papilloma larynx. How? We put this question, a 3-year-old child presents with persistent hoarseness of voice for 2 years and recently developed stridor. What is your diagnosis? So this child has got hoarse voice for 2 years, a couple of years, now stridor. So this is a classical cause of multiple papilloma larynx. Now next question, this is about aparexual stridor in children, like other question. Suppose a 3-year-old or 5-year-old absolutely normal boy is playing with his friends. He doesn't have any problem. Suddenly he develops severe stridor. What is the diagnosis? So my diagnosis is foreign body in the larynx or tracheal airway. Okay, because after normal children, he's playing with the friends, suddenly he inhale, choke some foreign body. So this is called foreign body in the larynx. Okay. Now, this is all about aparexual stridor. Other question, suppose a newborn child presents with severe stridor, but normal cry. That means cry is normal, but they have got severe stridor, a newborn child. What is the diagnosis? So my diagnosis, laryngomalacia. Laryngomalacia is a congenital disease like congenital laryngeal stridor. It's a laryngomalacia. Here, the epiglottis is a huge omega-shaped epiglottis, classical omega-shaped epiglottis. If you examine the patients, you have to do a fiber laryngoscopy. You can get this on, or you can get the excess soft tissue neck laterally. You can also get some view. But usually, with the classical history, that any newborn child, if the breathing is normal, but abnormal stridor, cry when he start crying, normal cry. This is called laryngomalacia. How to treat laryngomalacia? Usually, it goes off when the child is growing. The larynx is initially flaccid, very soft, flabby larynx, but eventually it will straighten as well as it will make a fix. So wait and see. But if in severe cases, if you have really stridor, patient may need tracheostomy, or you can go for some operation. It's called laryngoplasty. You can excise the surplus epiglottis. It's called epiglotoplasty. Okay, so that is all about the stridor. Now, what about the partial stridor in children? That means stridor with fever. What are the causes? Number one is acute epiglottitis. Number two, laryngotracheobronchitis or croup. Number three, Lardwig's angina. Number four, laryngeal diphtheria. And number four, acute retropharyngeal abscess. So these are the 5 causes of partial stridor in children. Okay, acute epiglottitis, acute laryngotracheobronchitis, acute retropharyngeal abscess, Lardwig's angina, laryngeal diphtheria. Okay, now your clinical scenario in case of acute epiglottitis. Suppose acute epiglottitis is a serious disease. Is caused by beta hemolytic streptococcus. Sorry, is caused by Haemophilus influenzae type B bacteria. It's caused by Haemophilus influenzae type B. It's a bacterial disease. And that's why nowadays we introduce a vaccine called HIP vaccine, HIV vaccine. Now the patient classically presents with a 3 or 4 years old child presents with sudden onset of severe pain in throat. Okay, sore throat, difficulty in swallowing, dribbling of saliva, high rise of temperature, and stridor. So this classical condition is acute epiglottitis. If you don't treat the patient, it's going to die. And causative organism, Haemophilus influenzae type B is a bacteria. Now, what are the investigation? How to investigate this child? If you do a excess soft tissue neck lateral view, you can get a thumb sign. That means the epiglottis is very much swollen, so you can get a thumb impression in the soft tissue neck. It's called thumb sign. Now, but you have to examine the patients in intensive care unit or ICU. You have to just ventilate the tube, intubate the child and see how it goes. You cannot see with the indirect laryngoscopy. You cannot pass a telescope or FOL. You cannot. So how to treat this acute epiglottitis? Now, this is a real emergency, pediatric emergency. You have to take the patient in the intensive care unit. You have to intubate the child. You have to take a throat swab from child, or you can take a blood culture, and you can intubate the child. You can give intravenous antibiotic, ceftriaxone. Sometimes chlorpheniramine is the drug of choice, but nowadays it is not available. So you can give a ceftriaxone or triclosan injection, intravenous antibiotic. This is called ceftriaxone, and you also give some steroid, and you can intubate the child. And once the condition subsides in 2 or 3 days time, then you extubate the child. Sometimes if you are not expert of intubation, patient may need tracheostomy. So don't forget to give intravenous antibiotic and steroid as well. So this is acute epiglottitis. Now, another condition is acute laryngotracheobronchitis or croup. How do you deal with this? We say, suppose a 6-month-old child or 1-year-old child presents with very croupy cough, hoarse or harsh voice, croupy cough, abnormal cry, and temperature, low temperature, cough, croupy cough. And if we chest auscultation get a very wheeze, a huge wheeze in the chest, what is your diagnosis? So his diagnosis is a acute laryngotracheobronchitis or croup. How to investigate this child? You can get a X-ray chest, you can auscultate the chest, In this child, you also patient may need a respiratory support, ventilatory support, the ICU management. You give this is acute laryngotracheal bronchitis or croup is caused by a parainfluenza virus, and this problem in the subglottis, not the supraglottis. So the subglottic problem, lower respiratory tract. So you have to give a ventilatory support, interventional antibiotic, steroid, and some nebulizer, good nebulizer, humidification, good humidification, or humidified room. So this condition will subside eventually. A patient may need tracheostomy for tracheal bronchitis. So this is all about clinical scenario and stridor in children. In adult patient, like suppose a 60 or 70 years old male patient presents with persistent hoarseness of voice for a couple of years. So 6 months, 9 months, 10 months, persistent hoarseness of voice, and recently developed stridor. What is your diagnosis? So this is a classical case of carcinoma larynx. So my diagnosis is carcinoma larynx. Carcinoma larynx, we usually ask this question in this scenario. Etiology of carcinoma larynx, as you know, most important etiology is your cigarette smoking, your alcohol, there's some environmental pollution, but these are smoking, alcohol is the most important etiological factor of carcinoma larynx. Mostly it's commercial carcinoma, about 95% cases. Patient glottic carcinoma, supraglottic and subglottic. In our country, supraglottic cancer is very common, but in other country, about 65 to 70% is a glottic cancer, and supraglottic is about 25 to 30%, and subglottic only 1 to 2% subglottic cancer. In our country, supraglottic cancer is more common than glottic and then subglottic. Now, classical presentation, if it is a glottic cancer, patient presents with persistent hoarseness of voice, or if it is supraglottic cancer, patient presents with difficulty in swallowing or sore throat, and eventually the patient may present with stridor. So, carcinoma larynx, if this scenario, severe stridor with carcinoma larynx, how do you treat? The first thing is, as a patient of severe stridor, we usually go for tracheostomy, and then we go for endoscopy and biopsy, and then we plan the treatment option. Now, in case of carcinoma larynx, if the early stage, suppose carcinoma larynx early stage means T1 and T2 stage. What is T1? T1 means when the tumor confined to, I think time is, what's the time? Oh, yes. I think next class, actually, I will finish with the carcinoma larynx because this is very important chapter, carcinoma larynx, and then we will go for head and neck. Okay, so I think today I can stop this lecture today. And next week, inshallah, next Tuesday, I will just discuss some other scenario of carcinoma larynx. This is very important for exam, carcinoma larynx, and then we will go for head and neck. Thank you very much indeed. Today, actually, I don't speak Bengali because I thought I'm not used up with talking Bengali or Bangla. Actually, you know, for the last couple of classes, I just spoke Bangla, but I don't like that because in lecture classes, in medical classes, we should not speak Bangla. That's why today I did not use Bangla. If you have any problem, I don't think so that you will have problem because I usually speak very simple language. You don't have any problem of understanding this simple English. So next classes, I will discuss the carcinoma larynx and then your head and neck. Thank you very much. Thank you for watching this.